and all the members of the organization for inviting me to talk here. It looks like it's been a really interesting day, and I'm really looking forward to watching the Robotics Institute blossom the way it has all the promise to do. So I'm actually dressed like this because I'm about to go up to the operating room, and I think I'm going to miss the other session and do a neurosurgical operation for which I wish I really had a robot. And so we're going to do a procedure that I'll show some videos of with mechanical tools that have been around for about 50 years. And, you know, it's going to be a relatively safe operation and it'll likely be successful. But I know that if I had the robot that we've been working on for these past years, that we could do it faster, safer, and with a better outcome. And so that's the sort of thing that we're trying to do at CIGITI. And, you know, CIGITI was already a mouthful, and I'm very happy to announce actually that we're now the Wilfred and Joyce Poslan's CIGITI after very generous donation from a family to name our group. So we're very happy with that. And I noticed that Andrew Goldenberg is on the next AMA discussion, and he and I have been at this for a long time, like 30 years. And this was a robot we designed in the early 90s to do neurosurgery using an industrial Puma robot. And what was the stereotactic frame at the time? This is what the graphics looked like. We wrote our own graphics. We wrote our own computer interfaces. We brought this up into the operating room, and we did 4 operations with it. And very quickly, it was surpassed by a passive robotic system that I'm showing here. And the graphics improved phenomenally. And now every neurosurgical procedure virtually is done with image guidance of some sort. So not robotic systems necessarily, but image guided using relational databases and reference systems. So it's become pervaded throughout the neurosurgical community. And medical robotics is really starting to, I think, take off. And I'm just showing here some of the more neurosurgical robots that are currently in use. The Da Vinci has not been used very much for neurosurgery, but is used throughout the world. These are more recent neurosurgical robots, and the commercial market for these is enormous. And so I think there's a huge potential in the medical robotics area. And this is another very simple neurosurgical robot that we now have in our hospital, and it puts a laser fiber into the brain for us to treat very small lesions at the very center of the brain you see here. So these are very hard to get to by any other means, and we do the whole operation in the MRI suite, and the temperature in the lesion is monitored throughout the procedure. So this is where the whole area, I think, in neurosurgery and in other areas is going. So minimally invasive, image-guided surgery, and this is where I think what is really important, and why I'm so pleased to be part of this, because I think we need an interface between the clinicians and medical people and the engineers and scientists to come together to design things that people really need. And this is a book that we wrote several years ago with Waleed Farhat, who's a urologist, and those are 2 of our MD PhD students who came through CIGITI to work on projects having to do with robotics. And so that's what I think the future looks like. And this is what we have been concentrating over the last decade. So developing minimally invasive robotics tools, working on simulation and modeling, and image-guided procedures using MR-guided focused ultrasound. And this is the group that does all this. And it's a wonderful mix of engineering students and students from the hard sciences and medical residents, medical students, and biologists interested in developing technologies for medical applications. Okay, so there. And so these are some of the things that we're working with. You can see Andrew Goldenberg's part of this. This is an MR compatible biopsy robot that we initially developed to work on doing bone biopsies, which is hard to do in an MRI scanner. But we're also repurposing this basic design, which is modular for both prostate treatment and hopefully neurosurgical interventions. And this is the MR guided focused ultrasound machine. And it has a transducer, which focuses the ultrasound, which heats or disrupts the tissue. And it's actually a robotic system. So it has 3 different axes of motion. And of course, the MRI system itself is in some sense like a robotic system. And there's been a lot of interest in this. So I'm showing some of the faculty that are associated with the robotics and tools groups. And you'll notice that Eric Diller's there and Hanny McGee and others who've been very involved in this process. And Goldie, who just talked, has been on some of our graduate student committees and also as an external examiner. So our relationship with the University of Toronto is an absolutely critical one, and one I think that is going to move this whole area forward. And we have a similar type of setup for the MR guided interventions. And I'm just showing similar groups. And it's beyond Toronto. We have relationships, University of Waterloo, Johns Hopkins University, and University of Western Ontario, and Kingston at Queen's. So I think it's a very robust way to collaborate. This slide's a little bit out of date, but basically these are the number of engineers and students we have in the lab, and we've had a very large number come through, many as co-op students from the University of Waterloo or from University of Toronto students as well. And we've also tried to get people interested at even an earlier age. So these are high school students who participated in a challenge to build a robot to do a brain biopsy using Lego Mindstorm. So my particular interest is on neurosurgical robotics. And these are the kind of procedures, and very much like the procedure I'm about to go and do, where we go into the center of the brain, I'm showing here, and try and remove something or create an opening, rather than doing a very large craniotomy where we have to remove a large part of the skull, very large incision, a lot of blood loss, there's a significant amount of risk. So we're really trying to minimize the impact we're having on patients. And so this is a view inside the brain, and this is the small tumor here that you can see that we're trying to remove. And you're going to see the instruments that we're about to use are actually quite primitive. And I'm not going to show the whole video, but so that's a grasping forceps. So we're just going to take a bite out of it and hope that nothing starts to bleed very much. And then we're going to use a tool that we're going to use to sort of take little chunks out of it. So really pretty unsophisticated. And this is basically all we can do at the moment, because if we get into bleeding, the operation can't continue, and we really don't know for sure what is beneath where we're operating on. And this is a paper that illustrates some of the problems with the tools that we're trying to develop. And so one of the areas we've been focusing on is concentric tubes. And I know that you're familiar with this, so I won't spend a lot of time on it, but we think it's one way of miniaturizing the robotic systems so that they are not only versatile, but also robust. So as you scale down a Da Vinci wrist, for example, you get to a system where either you can't build it, or if you can build it, you can't assemble it. And if you do assemble it, it'll just break, just because these things don't scale very well. So we've been looking at concentric tubes, and these are some of the design requirements, but this is what we want to do. So this is inside the cavities of the brain using a concentric tube robot to remove a tumor. And that's our kind of ultimate goal. We've had several iterations of this, and this is one of them. I think Zoe showed a simulation of this with a system somewhat like this. And this is what the versions look like. And we're using a haptic device in order to control them, building a system with a master-slave components. And this again is showing the typical instruments that we would normally use but which are not dexterous, so scissors and forceps. And we've had some progress. So this is using the system, that's a standard peg transfer, which is pretty standard robotic test. Sorry. But this is what we can't do now. So we can't actually go in there very easily and pick something up and cut it. We just don't have the ability. We can't, we're working in parallel. It's very awkward. And with this system, we can actually do that. So that to me, I think is a huge advance. There, okay. And this is our version 3, and we build models actually of the brain. These are of patients in order to test these devices, and these are for different applications, such as for epilepsy surgery, where you want to disconnect various parts of the brain using this device. Instead of a huge operation that takes, you know, most of the day, you could actually do this very quickly through just a single small burr hole. So the patient could potentially just go home that evening. So that would make an enormous difference in so many ways. We are working on modifying these tubes to improve their mechanical performance, so they don't get into these areas of high energy where they suddenly move, and developing other systems that are more dexterous but maintain significant amount of strength. And we've had a number of capstone projects through the University of Toronto mechanical engineering, which we're very pleased with. And we're using a Da Vinci as a test bed for devices. So we have a robotic system that we can just plant robotic tools on, and this is an example of one. And we actually won a competition with this, and I'll just show it to you in a second. This is a concentric tube for neurosurgery. So very pleased with that. This is at the Hamlin Medical Robotics Conference. And this is one of the capstone projects. So as I said, one of the big problems with endoscopic tools at the moment is bleeding. And at the moment, we don't have a good way to control it. And if you're working in an underwater environment, bleeding makes it very difficult to do. So this is another Hamlin Robotics challenge. And here's our bipolar, which is robotically controlled on the Da Vinci system. And we're going to cauterize lemon. So yeah, so that's the sort of tool that we think has huge promise. And this is another Da Vinci system based on these compliant tubes that are notched and have various configurations in order to make them dexterous and work and are 2 millimeters in diameter. And as I said, this is the ultimate goal. This is a collaboration we have with Boston Children's Hospital on designing a robot to work actually inside the MR, so an MR compatible robot. And this is also a recent design. This is a tool to work inside the ear. So instead of making an incision on the side of the head, you actually do everything through the, I don't want, yeah. So work inside the ear. And what I wanted to show you at the end, so this tool, we've actually used the tool itself, not the whole robotic system, in a single patient. So we actually have got a robot to a patient, a robotic system to a patient. And then these are other systems. This is for cleft lip and palate surgery. And again, working very hard to miniaturize the tool. So standard Da Vinci can be used in a large adult, but not in a 8-month-old infant. And so scaling for pediatrics is really important. And if you are able to scale something for pediatrics, that also means that you can use it in adults in a more minimally invasive environment. So that's one of the areas that we're working in. And we're also working on feedback. So the Da Vinci system has no force feedback. Force feedback is really hard to implement in a robotic system, as all of the robotic experts here would tell you. And And that's been one of the reasons that it's had some significant complications with the Da Vinci, and that why training is so important. And this is a bone conduction feedback system that was developed for our Da Vinci test bed, which worked quite well. So it's not just the robotic tools, but also part of the feedback system. And we're also very interested in fetal surgery. So I think in the pediatric sphere, the fetus is probably one of the next frontiers. And so there are more and more abnormalities that we are detecting in utero that previously were not able to be addressed. And now, through an evolution of surgery where at about 24 weeks gestation, we can actually open the uterus and do surgery. And so we do this very frequently now for patients with biomeningocele. But it's fairly traumatic for the mother, and that they have to have 2 cesarean sections. They have to have a cesarean section from there on. They have to be delivered slightly prematurely, and there's complications related to premature birth and so on. So doing this through a robotic system is something that we would think have a huge advantage. And so here we're using a Da Vinci SI system on a very realistic model of the fetus in order to do a repair, at least in this model with a Da Vinci that would take 10 minutes. Takes in a real live fetus about 3 hours. So I think there's a real future with fetal surgery. And then also for craniofacial surgery. So these are templates to help reconstruct the forehead to produce an outcome that would be normal for that particular patient. So these are designed for the individual patient to make their forehead, which may be very pointed, for example, into a more normal configuration. And we're working on tools to do this in a minimally invasive fashion. So this is a robotic bone cutting tool that could be used for craniofacial surgery. So as I said, the MR-guided focused ultrasound system is a robotic system, and we've been working on it to develop new applications for pediatrics. This is a benign bone tumor, and this is a hemorrhage, animal model of what happens very commonly in humans that are born prematurely. So hemorrhage is a very serious complication that results in problems with accumulation of fluid inside the brain and leads to long-term disabilities and a number of different problems. So if we could treat this non-invasively, it would be a huge advance. This is the first patient in Canada that we treated for a bone lesion using this system. And these are some of the robotic systems we're designing in order to go through an infant's skull to create lesions and lyse blood clots. This is a schematic of the robotic system that we put together. And then this is an example of the system that it's being tested. There are a lot of other applications for focused ultrasound, including doing liquid biopsies. So you can, with different energy amounts, not thermally coagulate or not disrupt tissue, but just disturb it enough that using microbubbles, it'll release tumor markers that you can measure in the bloodstream. So you don't have to actually put a probe into the brain and take a piece of tissue. We can now do this to some extent by just looking at the spinal fluid, but this way you could do it just looking at a blood sample. Motion compensation is a big problem for places outside the brain because with breathing, the diaphragm moves, and so for applications inside the abdomen, this is also really important. And making sure that the ultrasound beam is known. We're also using this for fetal applications, as I mentioned. So we're not working on robotic tools, but also non-invasive ways of treating the fetus with focused ultrasound energy, and this is a animal model. So I've run pretty quickly through all this. I just wanted to give you an overview and stimulate your thinking about what applications we can develop for medical treatments that we can actually bring to patients. If we can't get it to a patient, it's not going to have a lot of impact. So that's also a really important part of what we do, and developing intellectual property and getting these models or devices to patients is where we want to see them. I thought you'd be interested in this. This has nothing to do with neurosurgery. This has to do with patients who are struggling on a ventilator and can't be adequately oxygenated because their lungs are extremely stiff. And it's called acute respiratory distress syndrome, or ARDS. And it's very common, and it's particularly common in patients with COVID. And so one of our anesthetists, who unfortunately passed away, developed this robotic system to treat ARDS. But when the COVID pandemic hit, we got approval to use this device in a clinical trial by Health Canada in 1 day. And so it has gone into clinical trials, and it is one of the simplest robotic systems. It's a 3D printed cage that goes around the patient's abdomen, and it's controlled by an Arduino. So that's the kind of thing I think that we can do. So I'll finish up there. I think that medical technology and medical robotics are best driven by clinical need, and that's why I think it's important to have clinicians such as myself involved. I think this collaborative venture is the way to go, with a wide variety of experts. And there's a lot of interest in this, not only from the clinicians, but also from various graduate students, which we're really excited about. And pediatrics in particular tends to get left behind, because although you can argue children are our most important resource, you don't have to convince me of that. They are the future. They're a small part of the medical business because children are generally healthy. So we have to look after the pediatric patients and not use adult tools on pediatric patients. And I'll end there, and thank you very much for your attention.
Thank you so much.
This is very, very cool. I was trying to take notes and then I gave up because CIGITI and you are doing so much stuff.
I probably went too fast.
No, I think this gave the audience, particularly the students, the breadth of topics and the breadth of places where engineering can help, which is actually very, very useful. It's not necessarily about the sort of particular solutions, but the fact that interventional surgery can be helped with engineering solutions, both in terms of design and software throughout, is something that is very sort of anybody looking for impactful problems, here it is. Okay. So questions for anybody? Feel free to put your hand up. I can bring you up, or type your questions in the chat. While we are waiting for questions, I have a few questions, slightly sort of higher level questions. So you presented a number of these ideas based on certain ideas, let's say the concentric tube ideas, and even let's say ideas where we can have robots which have very small port of entry, and then they can, in your words, snake around. And these applications can be in fetal surgery, perhaps in neurosurgery as well. But often, this is a topic of interest for over 15 years. What do you think, or what would you say have been the challenges in this space that have prevented or limited the transition to clinician usage?
Yeah, so I think that there's a number of them. I think, first of all, these are very complex systems, and as you develop them, you begin to understand some of the limitations. And for the concentric tube ones, what I talked about briefly was this energy buildup and snapping. And you'd have to have this very much under control before you could ever bring this to a patient. So that's an example. And then there's the whole commercialization piece. And we've had one successful startup that's been bought by a NGO. But that is a very difficult road, and it's often some of the more simpler notions that can get to that stage. And so you actually have to go through this whole process of commercialization before you can actually get it to a patient outside of a research study. So you can do a research study, and that really improves, I think, your ability to demonstrate that this is actually efficacious. And then you can get other, corporate entities potentially interested. I think the final challenge for all of us is going to be to prove that these are actually better. Like I'm convinced that they're going to be better, but even the Da Vinci, there are questions about just how effective it really is. And so that I think also is an important part of this.
If I could just interrupt a moment and invite everyone to turn on their video screens and join, since we're now moving into open conversation. If you need to take a break, please do so, of course. We'll be sort of formally starting the faculty AMA soon, but just wanted to take a moment to allow everybody to join us. Let's all talk together.
So we'll do the faculty AMA in I think it's scheduled for 3:45. Am I correct, Kimberly? Yes.
So Kimberly, before we let Dr. Drake go away to the OR, I have a quick question. I never heard of a One Day Health Canada approval. I really want to hear more about what does exactly the device do, and how did it go through so quickly?
Yeah, so it's a very simple device. It's a cage that goes around the patient, and it has a plastic seal, and it's built in the same concept as the iron lung. So in the polio epidemics in the 20s and 30s, they built iron lungs that created a negative pressure that allowed patients to breathe if the polio affected their spinal cord to the point that they couldn't breathe. And this is the same idea, only it's only for the abdomen. And so it just goes around the abdomen, and it creates a negative pressure around the abdomen, and that allows the lungs to expand more down into the abdomen. And that improves the ventilation in the patients. And that it came from an idea from one of the intensive care doctors who, this is a real problem in adult and children's intensive care units, is not being able to ventilate the patients, just because their lungs are filled with fluid and they don't expand very well. And the big problem with the COVID epidemic was access to ventilators. I mean, that became a problem around the world. There just weren't enough ventilators in the areas that got really hit hard. And these patients tend to be on the ventilators for a long time. And so they can be on the ventilator for 2 to 3 weeks. So something like this could have had a dramatic effect. And I've never seen anything approved by Health Canada either. I mean, the clinical trial was kind of all ready to go. And as I mentioned, unfortunately, this individual passed away at a young age, but it was ready to go, and then one day it was approved, and so it went off into clinical studies.
Well, wonderful. I think it shows again simplicity and functionality are most beautiful. It's useful stuff. Thank you.
Jim, a great talk. Thank you for telling us about all those great projects. I'm wondering if you could tell us about what kind of training you give to your engineering students, which might be interesting for, I think most of the people here are engineering students. What kind of training do you give them in procedures or medicine to have them be effective for working on these projects?
Yeah, so I think that there's kind of 2 areas of knowledge that don't overlap all that much, and that's the anatomy and physiology of the human body, and then there's the engineering sciences. And so many of the engineering students that come to us, they take a course in anatomy or physiology or medical applications or imaging or something like that. And I think more importantly is we partner in the lab. There's this mix of medical and engineering students, and they, I think, cross-fertilize information very well. We do we used to be able to bring students into the operating room fairly frequently. That's all been changed with COVID. There is video monitoring that they can have access to, but and by the same token, many of the medical students that come our way, not medical students, but medical surgical residents and so on, they often have an engineering background, and so it's not the same as someone who's a postdoc from an engineering PhD thesis, but nevertheless, they do have a fair amount in common and they can cross-communicate pretty effectively. And then the other model that Eric, you know so well, is that we often have co-supervision between, medical individual and an engineering faculty. And that sort of covers both bases in terms of supporting the students in making sure that that the knowledge that they need to do their thesis is sufficient, and that they have access to people that they can go to get the information they need.
Yeah, great, thanks.
So we have one final question that is from non-engineers, and I think that would be a good idea. So Amy asks, as a public health educator who's not an engineer, how do you recommend we build public trust or patient trust for use of such cutting edge technology? And is there any resistance from such usage?
Yeah, it's a very interesting question. It's usually the opposite, and patients want the latest technology, unproven or not. And so, I think to an extent, right? So, lasers and, the Da Vinci robot, a lot of it is, someone with prostate cancer, they've heard all about the robot and they want to have their procedure by a robot. I think the bigger challenge will be when we get to autonomous robotics. So I think that will be different, right? So if there isn't actually a human being who's not actually doing the surgery, but is supervising a robot, that I think will be a much bigger challenge. I think that the self-driving cars, I think that's going to help with this, but I think that it will be our duty to make sure that we can demonstrate that these are actually safer than than having a surgeon do the procedure. And this technology is also kind of all around us. So the jets are all landing themselves, right? The pilot's not actually landing the plane, and so I think as more and more of that becomes sort of ingrained in what we're doing, I think there'll be more acceptance. But there are levels of autonomy that are obviously easier to implement, but like full autonomy, I think that'll be a huge regulatory, but as has been mentioned also, I think a social hurdle.
It's wonderful that you mentioned autonomy. So one of the things that I am particularly curious about, and a number of hopefully students who are now interested in AI and computer science, or basically just software, that a number of advancements that you described today were design advancements. How can we build better tools to solve these problems? What is the role of autonomy in this?
Well, because I think that you can build tools that are actually better than a human, and particularly at smaller scales. And you can implement things like virtual fixtures that prevent a human from accidentally straying into an area that they weren't cognizant of. And so, I think you can design tools that are actually safer than a human. And so that I think is an important challenge, and I think that's where this eventually is going to head. I think it's going to take much longer than we probably think, but yeah. So I think there is going to be a real role for autonomy, and but I think it's going to be obviously at different levels, and having virtual fixtures is not, I suppose, not autonomy, but it is a control system which constrains what happens and would be very much part of an autonomous system.
while I believe that this is going to be a very wonderful conversation, but I would like to thank Dr. Jim Drake for providing us his valuable time coming out. And I believe all of us enjoyed this talk. So thank you. Thanks a lot, Jim.